Okay, we're going to talk now about parent work in the psychoanalytic treatment of disturbed adolescents. And we've handed out to you a table that is kind of a schematic description of working with parents through all the different phases of treatment, whatever the age of the patient. And in effect, what you have then in that handout is kind of an outline of a book that we have coming out next month about this parent work, which is something that's fairly controversial in the history of psychoanalysis, where traditionally people were trained to not work with parents. So we may have some good discussion when we finish. The description of parent work that we are discussing is an evolving model. It comes from long years of struggling with some treatments that never got started or were interrupted or terminated suddenly or prematurely. We were not trained to work this way, but over the years we saw that many of our difficulties, and those of our colleagues and students, stemmed in part from the lack of a clear model for clinical work with parents in conjunction with their child's or adolescent's treatment. We are suggesting a model in an attempt to address these issues. Working this way is not easy for us, and we doubt that it could be for anyone. There are many reasons for this. In previous work, we have detailed some of the historical, theoretical, social, and political ones. But the main resistance surely comes from the deep and intense countertransferences to parents that we all struggle with. Thus, we are often aware of defensiveness, avoidance, awkwardness, procrastination, and so forth in trying to implement our own model. In our book that's coming out next month, we point out that it is in relation to the imagined omnipotence of the pre-gendered or mother of infancy that we perceive the deepest and most persistent resistances to work with parents. As in all things psychoanalytic, this model is a work in progress. What follows is a brief summary and extension of work described both in an earlier series of papers and in this book we've referred to. Every model of therapeutic activity and therapeutic action rests on explicit or implicit assumptions. Here we will describe the underlying thinking that shapes our work with parents and illustrate some of the issues that arise toward the end of treatment. So the first assumption: parenthood is a normal adult developmental phase. Throughout this work, there is an underlying assumption that parenthood is a normal adult developmental phase. As we understand and use this idea, the phase of parenthood signifies the capacity to create, care for, protect, nurture, love, respect, and take pleasure in something or someone beyond the self. As such, it does not necessarily imply bearing and rearing children, although that is the context of our present discussion. Within the phase of parenthood, there are subphases that correlate with levels of children's development. Parents on a progressive developmental path show flexibility and integration of subphases. Others struggle with fixations and conflicts over core tasks within subphases and their interaction with conflicts and tasks of mastery in their children. Second assumption: parents and children are involved in a lifelong complex interaction. We assume that members of a family influence each other consciously and unconsciously throughout the lifespan, including grandparenthood, old age, and death, to both constructive and pathological effect. The nature of the internalized parent representation and the mental relationship with internalized parents have profound effects on adult functioning. Artists know this and use this fact to important dramatic effect. In the play The Unexpected Man by Yasmina Reza, the woman describes the hospitalization and death of her friend Serge. He was a powerful, influential man, a grandfather in his 70s. When he went to the hospital, he took a passport photo of his dead mother to keep him safe. In contrast, in Good Morning Midnight, Chip Brown describes the suicide of a 67-year-old mountain climber who wrote that he was killing himself to avoid suffering the indignities and limitations of old age. He was praised by many for his extraordinary life achievement and bravery in death. But the author presents a portrait of a person who actually totally cut himself off from his own parents in adolescence. Then he lost his own 3 children in their adolescence through death, suicide, and repudiation. The book suggests to us that without internal parents to keep you safe, it is hard to grow old. In a seminal paper on work with parents, the late Erna Furman stated, quote, "The ongoing mutual narcissistic investments between parent and child matter not only at the start of therapy, but have to be taken into account all along. When we disregard the parent, we leave out crucial parts of the child's self, sometimes the best parts. And when we treat the parent and disregard the child, we commit the same mistake." Third assumption. Analysis of children and adolescents has dual goals. First is the restoration of the child to the path of progressive development, and second is the restoration of the parent-child relationship to a lifelong positive resource for both. Our view of the parent-child relationship provides a framework for evolving a technique of parent work which encompasses both the resistances and the developmental aids to therapy. The aim of child analysis can be recast as not only the restoration of the child's progressive development, but also as the restoration of the parent-child relationship that has been disrupted by pathology to its potential as a lifelong positive resource for both. Thus we are mindful throughout child or adolescent treatment of these dual goals of the work. This idea is not only an implicit assumption, but also an active and explicit assertion. We tell the child or adolescent patient and his parents early in the evaluation that we have these 2 goals for our endeavors together. We work with this idea until it becomes an intrinsic motivation for continued treatment. 4. The Therapeutic Alliance is a conceptual framework for ongoing parent work. Parents' intense wish to do right by their child, to be the best parents they can be, regardless of degree or type of interfering pathology, is a powerful motive force for entering into a therapeutic alliance with the analyst. The framework for discussion of parent work that we use is our revised concept of the therapeutic alliance, which includes building and maintaining an alliance between therapists and parents, between the parents, and between the parents and the adolescent, and of course between the therapist and the patient. Looking at the therapeutic relationship through the lens of the therapeutic alliance explicates and operationalizes analysis as a developmental experience for both the patient and the parents. The 5th assumption is in regard to the phases of treatment. We have found it useful to apply the developmental point of view to the course of treatment. It has allowed us to think of psychoanalysis in terms of phases, therapeutic tasks, and assessment of accomplishment of those tasks. That is, the outcome of therapeutic interventions at any given point in the treatment. Applying developmental concepts to the process of therapy, one can speak of phases of treatment, from the evaluation and beginning, through the middle and pre-termination, to termination and follow-up. Each treatment phase has its own nuclear conflict that is experienced by everyone. The patient's ego has the task of solving that conflict. How he or she solves it reveals particulars of the individual patient's history and current functioning, and how the analyst responds varies with the skill, training, and orientation of the individual analyst.
From this part, you could follow what I'm reading with the chart we've given you, because I'll be talking about the therapeutic alliance tasks. Everyone is faced with the same nuclear conflict, so we can describe the therapeutic relationship in terms of the tasks that face each and every patient and each and every analyst, as well as significant other parties to the treatment, such as parents, throughout their work together.
This chart does not have the therapeutic alliance tasks by phase.
Ah.
Don't be confused that you're
Yeah,
not
yeah.
reading the same things. It has the phases, but it doesn't have the therapeutic alliance tasks.
Yeah. Parents.
Oh, it does. I'm sorry. It didn't have the therapist's ones.
Yeah, this is one we made which has to do specifically with the parents. And we have another chart which looks at all the tasks of the patient and the therapist. This one's about this is one where we have the parents in there. So parents have the therapeutic alliance tasks throughout the child's treatment. Starting the parent work during evaluation invites participation in initiating these various transformations. One of these, you should look at them in the parental. I guess we don't have the actual task. The task for the parents here in these various transformations, one of them is shifting guilt to usable concern, which is, I think, an important task. And the parents will come in very guilty, and the guilt is traumatizing. It's like they have to run away from the guilt because it's so overwhelming, the feeling that they've done something terrible. They're responsible for their child. They feel they've done it, which is one of the reasons they'd like to run to medication or some other form of treatment.
Or biological explanation.
And that's what makes therapy itself a very, very difficult thing for a parent. So I want us to really engage with the parent around this and help them move from the guilt, which is a kind of omnipotent belief that they, I'm sure they've contributed to their child, but they're not solely responsible for it, to usable concern, to be able to help them feel that they are parents, that they're concerned about their child, it's their concern that brought their child into treatment, and that this is good. This is a good thing. They don't have to feel guilty as if they're responsible. They do have to feel concerned. And share with them that there are many parents of children who may even have worse conditions. They don't even bother to bring them to treatment. That they are really to be commended for bringing their child to treatment. And just to look at the kind of anxieties that they have during just the evaluation. And these, when we say engage in the transformation, that's their task. And the therapist's technique, primarily to acknowledge their wish to be a good parent. One of the things we suggest is to do as much work during this evaluation phase through the parent, as much as is possible. So, and often the parents will say, pediatrician or the doctor or the school or whatever it is, here's the child, you cure him. And we try to very much hold off on that, and we try to work with the parents to help them feel that they are important, that they are a central people in the child's life, and let's see what we can do through them. All the way from advice to maybe even working on some of their initial blocks and what's happening. And to see what happens. And if, in fact, it begins to work and there's some changes take place, you then have an ally. You have someone who's enormously grateful to you and are willing to work with you. And then when they reach the limit of the work, then we could say, look, you've done a great job. They're so much better in this and that. They're no longer anxious. They're able to go to school. They're doing well, but they're very sad, very depressed. So I think this is a good time for me to see the child and see what the depression's about. And they say, oh yes, I think you're right. So that's going down through there. It's what the therapist does. You do as much through the parents. You try to access the primary parental love. I mean, parents will come in, especially now we're talking about adolescents, they're so angry, so upset, and they really want to blame the child or blame anyone else they could. And they're furious, and quite often they just want the child or the adolescent punished, and they expect you to punish the child. And you want to help them get back to what we call the primary parental love, at least some indication to them and then to us that there is a kind of basic love they have for this child, even though it may be covered up now by years and years of antagonism, battling and fighting, but somewhere. And we may even go, what did you feel when your child was born? What was the infancy like? And bring back memories sometimes. Oh, yeah, I remember he was 4 years old and we did this and that together. And they'll begin to cry. And you could really feel they've come back to something they've been out of touch with for years and years. And then you feel, okay, we have a basis for working here. And so all these things, clarify the contract, especially with adolescents, you want to differentiate privacy and secrecy. Okay, so we'll go into that. At the beginning of the child's treatment, parents have the task of allowing the child to be with another adult, accepting the physical separation. So once you're going past the evaluation and you say you are going to work with the child, then they have to accept that that child's going to a stranger, going to someone they don't know, and is going to have a very intimate relationship with a stranger, and they have to allow that. There's a lot of anxiety about that. They feel they're going to lose a child's love, and they feel that they're going to be overwhelmed with their guilt, that you're going to be a better parent. So in the middle phase, just to run through these quickly, in the middle phase, it's allowing the child to work together privately with another person. This means integrating the child's psychological separation. And then you can really differentiate for the parents the difference between the physical separation and the psychological. And that is a very difficult time. It's quite often when parents will pull the child out of treatment, or the child will do something to make the treatment end at that point. Because at this point the child is very attached to the therapist, and there's going to be it's a psychological separation that's occurring. It's not only the physical, but psychological. The child is going to be accessing parts of him or herself. They're going to be developing parts of himself, and the parents feel, well, I won't know what's happening. I won't know what my child is thinking, what my child is feeling. The child's going to have a private space, and that's very, very difficult for parents. We go into the pre-termination, and here it's very important to, if they've allowed you to work with the child in the middle phase, then that's where the symptoms just go away, and the child's doing well on all fronts, and the parents say, okay, can we stop now? And you want to start talking during the middle phase of how it's going to move. And you talk about in the pre-termination phase what you want to do, what you want to accomplish with the child, and how important the ending, a good ending is. And so you'll start talking about this earlier on with the parents. And with this, if you have in mind what you want the child to be doing, to consolidate the gains, to be able to internalize some of the work that's been going on in the therapy so they can do it for themselves. And you share that with the parents so they really begin to understand what the goals are and why, since the child seems happy and is doing well, why he has to continue to work. And then the talking about the termination. And they begin to understand this in terms of learning how to say goodbye in a different way. Learning to have the emotional muscle to bear the sadness and to bear the love. And to be able to love someone else. And the parents allowing that to happen. And here you can talk about adolescence and what's going to happen, how are they going to leave in adolescence. And this is a preparation for it. So, let me go into a case. Okay. So the parental tasks we're talking about here support the patient. They support the patient's mastery of his or her own therapeutic alliance tasks. And we're going to try to illustrate some of this with, the reason we're focusing on an adolescent here is because most child analysts, the field is really moving and people are beginning to accept the importance of working with the parents. But definitely not with adolescents. The whole idea of adolescence is a kind of separation, that the adolescents will be totally separate, and there's a real difficulty of privacy and all that, and confidentiality. How can you How can you see the parents if you're working with the adolescent? So that's why we're bringing this to you. The model we have about working with the parents, we're saying not only just work with the parents, is that there's a kind of parallel that goes on between where the adolescent or child is, what they're working on, and what the parent is working on. And quite often you'll see the child gets stuck because the parent hasn't worked through some particular aspect. And once that can be engaged with and worked on, the child can move forward. And there's parallel work that goes on. So here's an example of pre-termination. Pre-termination work with Mark. He came to analysis after making a very serious suicide attempt. They just, being Ann Arbor with these big medical centers, and they just could pluck him out of his wrecked car and get him to the ER, and he was saved, pure luck, and he lived. And so here we were in the pre-termination phase. Mark and his analysts had explicitly entered into a pre-termination phase in which they assessed his readiness to begin a termination phase. It was clear that he was ready, but something was keeping him back from moving forward and actually choosing a date. Mark's parents were relieved and pleased with their new level of relationship with him, but worried about ending treatment. So the first task for the analyst was to help them with their anxiety that without treatment and the analyst, Mark would revert to his suicidal sadomasochistic functioning. They lacked confidence that he and they could independently sustain a loving relationship. The analyst first took up Mark's parents' anxiety by affirming that nothing would be decided until they could explore the reasons for their concerns. Soon after, the father emailed his insight that one of his worries about the end of Mark's treatment is that he, the father, would be, quotes, out of a job. If Mark doesn't need me to stay in treatment, if he can take care of himself, then he doesn't need me to protect him, and then what's left? Wow, I have to keep him a helpless child so that I can be a valued father. What a crock of shit. Mark and I have so much more going for us. I realized that my anxiety about his mother was really an anxiety about the end of my usefulness. What else is there? See you next week. Before the next meeting, Father wrote, there's more, my envy. How I wish that I could have had analysis at his age. Perhaps I could have been as happy and creative and productive as he is. Isn't it strange to envy my own son, even when he is benefiting from what I have provided for him? What next? See you Tuesday. Next was Father's awareness of how angry he felt with his own father, who had been the passive bystander, while his wife, Mark's grandmother, controlled and abused the children. He was angry and sad during the session. He said, I don't know how many generations of my family men carried on the pattern of marrying powerful, controlling, abusive women and stood by as their own children were destroyed. I've been in my own therapy for years. I've been helped in many ways. I'm very grateful. I'm very grateful, but it's only in our work together on my parenting that I could see and feel this repeated pattern of allowing our sons to be abused. I hope that it's not too late to stop this. I hope the change in my relationship with Mark will provide him with a different model of how a father can be. He then wondered if he could get enough done before Mark finished treatment. The therapist said that they would work until the end, but if necessary, they could continue working on parent issues after Mark ended. Father seemed pleased that he wasn't working under a time constraint, but then canceled the next session, claiming pressing business needs. That evening he emailed, I'm sure you didn't believe the bullshit about work. I did have urgent matters, but I always do. I had convinced myself that I couldn't spare the time. I first realized that I couldn't bear the thought of Mark surpassing me, being more successful, happier, and nicer than I am. But then it struck me that I am talking about my surpassing my father. This is an issue I've worked on in my own therapy, but never in terms of my being a better father. For years I've worked on my guilt for surpassing my father physically, sexually, academically, financially. This must be the last battle. A part of me wants to be as bad a father as my dad was with me. Can we meet an extra time this week? Now soon after this, Mark cleared the last hurdle of the pre-termination. I mean, this was going on independently, with Mark's permission. Because Mark, initially we worked, I would say to Mark, I'm going to meet your parents, you want to come, it's up to you, come or not come. I'll tell you if it's anything that's of importance to our work, but otherwise they have issues. So he came for a while, and then he just got bored because he realized they were really talking about their issues, and that it impacted on him, but it wasn't directly. So he said, go ahead, I trust you, I know you know what you're doing, so go ahead. So this worked now with the father about termination and ending. I told Mark what it was about, but I didn't tell him any details. When the father got to this point about fear of surpassing his father, being a better father than his father, Mark just cleared the hurdle himself. He felt ready and confident to start a time of saying goodbye. And the next week he chose a date, 3 months ahead, for finishing his analysis, and the termination period could begin. At the next few meetings, Mark's father spoke of his enjoyment spending time with the son. It's like having a fascinating friend. I love to listen to him talk about his work and his life. I don't mind when I have little to add. It's just wonderful to listen to him. I feel so proud of him. His new venture is filled with risks, but I'm confident he'll make it work. We arrive now at our last assumption about parent work on the basis of experience of the depth and complexity of such work as we have just described.
So the last assumption is that parent work is substantive and legitimate and makes full use of the repertoire of psychoanalytic interventions. Developmental interference in parenting can be understood as pathology that is amenable to therapeutic work. It follows then that we consider it necessary and appropriate to use the full conceptual and technical repertoire from individual work with children and adults in the context of parent work. We do not define parent work negatively, that is, in terms of what it is not or what the restrictions may be. Rather, we see it as substantive, significant, and legitimate in its own right. Parent work therefore includes interventions traditionally labeled as therapeutic. For example, analysis of defenses, verbalization, insight, reconstruction, interpretation, and the use of transference and countertransference for understanding and technique. In our experience, use of the full range of therapeutic techniques in parent work does not compete or interfere with individual therapy for parents. Indeed, parent work may lead to acceptance of a referral for individual treatment while maintaining the relationship with the child and adolescent analyst for work on parenting issues. Parent work focuses on the parent-child relationship. Other issues in the parents' lives are engaged with only as they have relevance to their relationship with their child. Thus, we may use the full range of our skills without inhibition in a very focused area of parenting.
Okay, thank you.
That's a short introduction.
We are so impressed with your ability to
Your stamina.
Your stamina.
And yours.
What about any questions or comments? Young?
Could you talk some about the practicalities of this? Is this a scheduled meeting?
Yeah,
Yeah.
yeah.
And it's most.
Talk some about
It's
the
an important
practicalities of how
question.
you arrange this.
Yeah.
And
I think it's a really important question because it speaks to the comprehensiveness of the therapeutic interaction with the parents. So we build it in as a regular dimension of the treatment. And different parents, different circumstances. We try to see parents as much as once a week if we can. But that does vary. But I think it's important that it's set up as a regular component of the treatment, because then it's not crisis related or problem related. if it's only crisis related, if you only see the parents when something's going wrong or the kid has stayed out after curfew or taken the car when he wasn't supposed to or whatever, you don't have a relationship that can contain all the mixed feelings that are part of such a situation. Whereas if you've seen them regularly, you know each other. You have a relationship. This was best expressed to me by a parent who said that they wanted to come to Allen Creek with their little child, not because they felt that they were particularly, bad parents or that they had any particular problems or that the child had any developmental issues, but they wanted to be someplace where the people knew, the professional staff knew them as people in their whole functioning, so that if and when something came up that was problematic, there would be a comprehensive view of them. I think that's true of the analyst's view of the parents of child and adolescent patients and of the parents' view of the analyst. Because if you've developed a working relationship, if you've been able together to master some things and understand some things and collaborate in gaining insights into the history of the family and the child's development, then when something blows up, you have some working capital. So logistically, practically, we build it into the treatment. And we also work in a college town where we see many late adolescents whose parents live far away. So sometimes that makes it difficult. So sometimes we've done late adolescent treatments where we never actually meet the parents. Sometimes there's phone contact initially when setting it all up. But otherwise, we very explicitly say to the college kid, one of the things we need to do as we work together is to legislate for your parents' needs in relation to this treatment and in relationship to your growth. How should we do that? How do you think you're going to communicate with them about what we come to understand and the changes you may go through? So we keep that alive, and basically, we talk about working with very small children and children through the parents. Well, here we're working with the parents through the kid, but explicitly. So we build it in.
We explicitly will say to the adolescent and the parents that the task and the aim of adolescence is transformation. It's not separation. And there's Anglo-American ideas, we call it. When kids 17, 18, you push them out of the nest, and that's it. You don't want to. And that it's not the physical separation, which is often substitutes for the psychological transformations which have to take place, which include transformation of the relationship to the self, but also to the parents, to other people, which include the parents. So we will say explicitly about we're going to work on your relationship with your parents also, and how you can change that, and how you can engage them to help them change. And so when things come up in treatment, you might say, well, they seem to be still treating you as if you don't have a brain, you can't do anything independently. How are you going to work with your parents on that issue? And they'll think about it, they'll work on it. And then you get an angry phone call from the father. What do you mean you told my daughter to do this and that?
What do you mean she has to pay the bill herself?
Yeah,
I'd like you to send the bills directly to me.
Yeah, it's like I don't want her to know about them. She can't handle money, so I want you to do it. And this goes on. It's a big issue around the payment. They give them big cars and everything else in the college town, but they won't, and they give them their own credit card, but they won't let them handle the billing from, with me, with us. So that becomes an issue, even though we'll never see those parents. And sometimes we will encourage the parents with the adolescent to come visit us when the parents come to town. And at least we give them the opportunity. And some parents don't want to take it up, but others do.
I'm curious how you handle discrepancies about what you know from the adolescent and what you know from the parents, even when people are being very honest, particularly when there's a lot of conflict, you'll hear completely different stories.
That touches on the $64,000 question about this, which is always the issue of privacy. And the traditional position about not seeing parents much at all, and certainly not seeing the parents of adolescents, was fear of contamination in either direction, and the problem for the analyst of juggling disparate information. And, how do you handle that? I think with mental discipline, but also part of how we solve that, well, there are two pieces of the answer. One is by having as an explicit goal the transformation of the relationship. So I would have no trouble saying to a young person, your parents called me up and they told me a completely different version of this. What is that about? Because they have to begin to communicate better. And so we'll also talk about, I'm uncomfortable hearing from your parents something that you don't seem to be telling me about. It would be much more comfortable between us if I heard from you what happened last weekend, etc. The other piece is the big distinction we make between privacy and secrecy. And we talk very explicitly with parents and children about this. Privacy is a given. It's intrinsic to psychological separateness. Nobody can read my mind. My mental contents are private. That's not, it's a fact. So, but secrecy is a motivated withholding of information as a way of having power. When if you think of second grade, we know a secret, we're going to tell you. That dynamic is a sadomasochistic power relationship, and that's how family secrets operate. And the family secret is imbued with this incredible destructive power. If the rest of the family knows this, it'll destroy X, Y, and Z. It's a major issue in treatment. So again, privacy is something which is in each person's territory, and it's up to them to share or not. Children have private thoughts, parents have private thoughts. So the therapist's role is to encourage them to change their relationship such that they can be comfortable deciding what to share with each other in terms of their privacy and maintaining and respecting their privacy. But that there shouldn't be secrets because that's a different kind of relationship that's going on. So it's a juggling act, but instead of juggling it alone, we think it's something that this network of interlocking alliances has to work with and juggle as a joint responsibility until we can sort it out. So it makes it harder work.
We'll say explicitly to the parents of any age, we'll talk about privacy and secrecy, and we'll say, but also the other fear that parents have, it's understandable, is that they could be excluded from something. That's why they would prefer, let's say, cognitive behavior therapy, where the schedules, they come home, they see what they have to do, the exercises, the stars, and the this and the that. They don't know what's going on in the sessions, and they're really scared of that. And I will tell them what's going on, but I'll tell them we'll talk in terms of privacy and secrecy. Say, look, it's no secret, but it's private. What they'll talk about, I'll tell you now, I haven't seen your child, but I'll tell you exactly what your child's going to talk about. Love, hate, fear, anxiety, revenge, and I'll name a bunch of things.
Death, birth,
yeah.
jealousy.
They're the same things you would talk about in therapy. This is what people talk about. This particular how he plays it out or talks about it, that's private. That's very private. And so he needs to know the private space that he can work out the themes which you know about.
The details are his own and they're private. But in general, what's happening is, we all have the same things.
And then there are ways of sort of including them without in any way violating the confidentiality or the privacy of this thing. We'll say, for example, if it's an adolescent and a high school graduate and he's going off to college, you can say, well, what's in the air now, right? What's in the air? What's in the air in your mind? What's your child going to be doing? Oh, he's going to college. So it's separation. You're concerned about it. You have feelings about it. You can imagine. What do you imagine? Now, the fact is we have been working on separation and what it feels like and all that, but I haven't, said, oh, your Johnny has been sitting there crying and he's so scared or he's so angry and that's how he's dealing with it. I'm saying this is a universal thing. Everyone who is leaving for college and who has a child leaving for college is dealing in one way or another with physical separation. And that's going to be something we're going to work on. It's not a secret. How he does it is private, but it's not a secret. That's a major, major task for him now, and for you. So we can open it up that way. And then they don't feel left out. They say, oh, yeah. It really is. I've been stressed out for the last few weeks thinking about which college. And I said, is it which college that's stressing you out? And I said, oh, no, it's really not. College. My kid going on.
How do you start, like, from the first phone call? I mean, do you see them as a family? Do you see the adolescent first, particularly with adolescents? Or are you seeing the parents first in this model?
It varies. It's
Based
not
on...
It's not a hard and fast model. For me, there's a rough age transition that, up to 15 or 16, it's usually the parent who makes the phone call. Even older than that, it's usually the parent who makes the phone call. But older than that, I may say to the parent, well, I'll say to the parent of anybody, any age, have you talked to your child about making this phone call? Has your child expressed a wish for help? And so if the parent of an adolescent says, yes, my child says he does want to talk to somebody, then I'll say, well, why don't you have him call me? And we'll see what we can set up, and I'll meet with him first, and then I'll explain on the phone. Always make sure there are 15 or 20 minutes for that phone call with parents. So if parents call me and I've only got 3 minutes, I'll say, when's a convenient time for us to talk a few minutes later? So then I'll say to the parent in an explanatory way, sometimes adolescents worry that their privacy won't be respected. So in order to obviate that from the beginning, why don't I meet with the kid a couple of times, and part of what I will be talking about with him, I say to the parent, is that we have to figure out how we are going to bring your parents in on what we're coming to and what we're understanding, and what kind of plan we want to make to address whatever the trouble is. So the parent knows that respecting the privacy is a component of the situation, but that I'm also going to make that an active discussion with the kid of how are the parents going to be involved. So I'll say, so I will see your kid 2 or 3 times, and then he and I will work out how we're going to bring you in on the process, whether that means us all meeting together, or whether you and your kid would be more comfortable with just you meeting with me. Otherwise, if the parent calls up and says, I'm so worried about X, but they haven't said to their child, and their child hasn't expressed any wish to talk to anybody, or their child has said, no way, totally, then I'll say, well, then why don't you come in and we'll talk about it and get a sense of what the situation is. And one of the things we'll talk about is how you can talk to your kid about this, how you can get to a point where you're all more on the same page about what would be useful in the situation. So it's very much in terms of exactly what's going on, but the goals are the same, and what's included in a dialogue is the same. It's just configured depending on the individual case.
It makes a big difference if you really think of parents not just as a source of information and money, but that they are an active part of the whole process. And then we'll be very explicit on the phone. But this is how I work, say. And it'll include you because you're an extremely important part of this person's life. And it sounds from what you've told me that there are issues in your relationship that should be looked at also, in addition to his depression or suicide or something like that. So it makes that very explicit. And so in a way, if we see the kid, like if it's a suicide kid and it's real emergency, and it's not so emergent that they have to go to the ER, but they've been having accidents, then I'll tell you, let me see him or her, let me talk a little bit, see if we can engage enough to feel safe about it. And then I'll get in touch with you. So it might be that. But quite often I will see the whole family first. And right there you begin to see all sorts of things. But you see the whole family, you get their story. And I might at those initial sessions say, well, look, can you go down and wait a room, I'll talk to Johnny alone, see what he says, bring it all together again. And but eventually we end up with a plan, and the plan always, in our mind, includes explicit work with the parents around transforming the relationship with parents. And that's part of it. And I will say, look, he has his own issues, he or she have their own issues, they need their private space to deal with, but we need to also work on this whole family relationship that's going on. It seems to be stuck. And you really want to make it evolve so that when they come back for Thanksgiving when they're 40 years old, it isn't a phony thing. It isn't oh God, we have to see the parents every day. Make it a really growing, mutually enhancing relationship.
I think that's a very good system. The main danger that one has with that, we tend to do the same, involve the parents in some form or another, but the main risk that you run, particularly with older adolescent, is that you may lose his trust, depending on what kind of problem he has and how much he wants his parents to be involved. So I generally make it quite clear to the adolescent that whatever the parents tell me about him, I will tell him.
Mm-hmm.
Yeah.
And I tell the parents, if there is something that you don't want me to tell him, don't tell me, because it's essential for this treatment that I don't keep secrets from him, just as it is essential that he doesn't keep secrets from me, and you have to clean that. And I tell the child the same. It's up to you. Some children will have enormous objection to that I will respect, and some adolescents, until there is a better time, at which point you generally can talk them into, your parents need to be involved in some form or another. But I usually tell them whatever, I will never tell them anything what you call privacy. That's private, and I will never communicate that to the parents, and I explain that to the parents first time I see them, that it's essential to this treatment, that I respect the confidence of his child, and if they want me to help the child, they will have to live with some degree of abstinence, that I cannot pass to them information of that type without his permission, and that ideally what I will want is him to tell them. If I can walk him into doing that. So I generally tell the child that whatever the parents tell me, I will pass down to him. And I generally tell the parents, don't tell me if you don't want me to know. Similarly, I tell the child, I will never tell them anything that is confidential, and I will always give you a short rundown of what it is that your parents and I discuss. So when I see the parents, next day the first thing I do is tell your parents were here and this is what we discussed. You know, without going in an enormous amount of detail, but it's essential to maintain the honesty
Exactly.
between the two of you, otherwise you can treat them. You lose them really
Yeah, it
very
has
fast.
to be explicit in as well.
But that's a very good system. And it's really true what you say, that a lot of people shy away from the possibility of seeing the parents. We just think it's a mistake. I particularly like the emphasis that you put in what it means to the parents, all of this, because generally most people that see the parents see them mostly to get some feeling for what is going on anywhere else, or because the parents want to be seen. But you are actively trying to help the interaction between the two of them and involving the parents in some form in a way that is very constructive for your patient, because it will improve the relationship. If you treat the child and the father continues to be an ass, he's going to have so obviously that's interesting and important. Yeah, very valuable.
Sometimes I had a 16-year-old a couple of years ago who was in big trouble, depressed and suicidal and hysterical outbursts about her boyfriend, and involved in a very abusive relationship with her boyfriend, just a mess. And her parents were, especially her mother, was equally hysterical, and they would have these screaming rows, and it sounded really horrifying. And the girl would not allow me to see her mother. I mean, a condition of her coming was that I not see her parents. And I tried my darndest. I did the whole shtick. Nothing. And she said that the reason I couldn't see her mother was that her mother would overwhelm and overpower me and brainwash me the same way the mother did her teachers and her friends' mothers and all this. And I was driven to saying things to this patient like, hey, but I'm really pretty tough. I don't think she can. It was ridiculous. So finally I said, well, okay, let's see how it goes. Well, what would happen was that when they would have these hysterical mother-daughter things, explosions, affect storms, the mother would call me up on the phone and start shrieking at me, this treatment is not doing her any good, and the mother would visit on me. So then the mother and I would be on the phone for an hour having a discussion. And over time, in those discussions with the mother, change began to happen. But I never had them in the office. I never did it properly. But the girl began to acknowledge that maybe some of the things I said to her mom on the phone were having some effect, but she still didn't want me to have her in the office. So, in the end, the mother and the daughter got on very well, and the daughter stopped having abusive relationships with boys, and then the mother wrote me one of those letters saying, I'm completely converted to therapy. I want to send my younger daughter to therapy. I'm telling all my friends to send their anorexic children to therapy. And, but I never did the work with the parents in the form that I would think was important.
But it's interesting too, the difference between the attitude you take in terms of your relationship to the parents of the adolescent and the latency or younger child, where you see them regularly, but with a completely different aim in mind. Because the adolescent is very capable of communicating to you what is going on in his life. Small child frequently can tell you, and you're watching play that you can decipher for a long time unless you talk to the parents and find out what the hell is going on at home. Otherwise you're wasting your time, because the child can't tell you, really.
The child doesn't even want to tell you half the time.
And sometimes he cannot. He can only do it by means of a derivative in play that you may not be able to decipher for weeks, And that's why you keep a running dialogue with the family. But of course you don't do that with adolescents. It's a different kind of approach, I think. Well, thank you very much, everybody. Those of you that want to come and eat, very good. Thank you.